Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really fascinating guest today involved in creating a better tomorrow on many unique fronts. Today, we have the honor of being joined by Dr. David Carmouche, who is Senior Vice President of Omnichannel Care at Walmart, where he's involved in leading the organization's fleet of Walmart health centers, their Walmart Health virtual care organization, their initiatives to address social determinants of health, as well as all new omnichannel healthcare offerings. He joined the organization in 2021, bringing a really unique combination of experiences as provider, payer, and as leader of an integrated delivery network, serving as a physician, as an executive for an insurance company, and a leader in a regional healthcare system. He joined Walmart from Ochsner Health, which is the largest nonprofit academic health system located in the Gulf South. There he served as president of Ochsner Health Network, executive director of the Ochsner Accountable Care Network, and executive vice president of value-based care and network operations. And before that, was chief medical officer and executive vice president of external operations for Blue Cross Blue Shield of Louisiana, introducing the company's first value-based care contracts there. He was the first lipidologist in Louisiana and a fellow of the National Lipid Association, and he practiced preventative cardiology in Baton Rouge to 2012 and built a very large multidisciplinary internal medicine and preventive cardiology practice there as a director of the Center for Cardiovascular Disease Prevention at the Baton Rouge Clinic. He also helped champion the EPIC electronic medical record, single instance implementation across 3 of their entities. Dr. Carmouche attended Tulane undergrad, where he studied biology, then off to LSU for medical school. Became board certified in internal medicine and completed his residency at University of Alabama at Birmingham, later serving as chief resident. He also serves as the president of the board of the Consortium for Southeastern Healthcare Quality and serves on the advisory board of Stellar Health. He's also a board observer and advisor for New Orleans startup Ready, and serves as nationally as a board member for the National Association of Accountable Care Organizations. A lot of really important topics to get into today. We're honored to have him with us. Dr. David Carmouche, thank you so much for taking the time to come on the show today.
All right. Thanks for having me. I appreciate it. And thanks for that really nice intro that my mom obviously sent you.
Absolutely. Well, it's great having you. I would love to start off, as we typically do, by just handing you the floor for a little bit to talk a little bit more about you and your background. If you've been on this amazing journey, if you could take us back to the beginning on how this started, what got you interested in biology, medicine, and of course, sort of lipidology. Start off us there, if you would, for a few minutes.
Yeah. Well, thanks. So, well, I guess, I was going to be a doctor from the time I was 6 years old. I'm the oldest of 4, and my mom was an elementary school teacher. And for whatever reason, when I was 6, she told me, you're my little doctor. And I don't know if it was because of a personality trait. I don't know if it was a belief or a hope that if she put that in my head at an early age, it would come to fruition. But I've never known a time in my life that I wasn't going to be a clinician. Certainly did well in school in no large kind of way, unrelated to her being invested in me and being a teacher and being super interested in education and giving me lots of support and opportunities. My dad working to send us to private schools when maybe the public schools in our community weren't the greatest. So was blessed to have really been given a lot of opportunities early in my life to do well in school, and really had oriented myself towards healthcare from an early age. I think there was a seminal moment that happened to me kind of senior year of high school into the first couple of years of college. My family, we moved from Louisiana to Charlotte, North Carolina when I was a kid. And my dad took a different job mid-career, and he and the family moved back to Louisiana at the end of my junior year of high school. And I was very enmeshed in my world and didn't really want to, leave for my senior year. And so was taken in largely by my best friend and his family for my senior year. And his dad was a family medicine doctor. And so had a great senior year, was really, really thankful. Fast forward a couple of years later, I remember getting hearing that he had died suddenly, 49 years old, tennis player, non-smoker, thin, and had a heart attack on a Saturday and was gone. And as I got through medical school and residency, this notion of how do people suddenly have those sorts of problems when they lived a reasonably normal life kind of led me down this path of preventive cardiology and understanding risk assessments and using modern tools and diagnostics to help people understand their special risks, and then managing that. So that's kind of how I got into the kind of preventive cardiology, lipidology, hypertension specialty world. And then the other really important part of that story is just that clinical model and practice became the genesis for me thinking a lot about how healthcare should be compensated or paid for. These were very complex patients. You needed to spend a lot of time with them to educate them. It wasn't conducive to a fee-for-service kind of transactional reimbursement model. The payoff was to the risk-bearing entity, whether that was an employer or an insurance company, who were in our experience seeing lots of folks who had very high risk avoid things like hospitalizations and heart attacks and procedures by virtue of the team care model that we were able to put together. And so it's really what started to kind of get my thinking around how incentives could influence care model design, and why I was doing it was for the love of it and for the mission of it, but that from an economic standpoint made no sense. And so again, you could kind of see the path from doctor to preventive cardiology to what has been kind of the second half of my career, kind of this really deep focus on value creation and the systems that have to be aligned to do that in healthcare.
That's really interesting. And before we will segue into your thought leadership in value-based care delivery and so forth, but I wanted to sort of hang out in the mid-2000s for a moment, because you build up this very successful cardiovascular disease prevention practice at the Baton Rouge Clinic. You're publishing at the sort of the late 2000s, sort of on the you were involved in the Jupiter study group, sort of beginning to think of sort of lipidology plus. So we have the sort of the lipid control and the statins. You begin studying things like C-reactive protein and the sort of this theme of lipids plus inflammation. And then you gave this really interesting presentation I watched in 2012. It was the Pennington Biomedical Research Center, entitled "Preventing Illness Through Routine Health Screening." And just a side note, in a sort of a previous career of mine, I was involved in some collaboration down there with Will Cephalou in the early 2000s, and he brought so obviously the whole diabetes thing in there, and you talk about diabetes in the presentation as well. Talk a little bit about sort of the evolution of just the cardiovascular, cardiometabolic theme, because it's morphed a lot, and clearly this is going to become a big piece as we get into what you're up to with Walmart and sort of diabetes and telehealth and all that. Talk a little bit about how you've seen that evolution as a practitioner over the years, if you would.
Yeah, so this goes back to kind of my time at UAB, which for those who don't know, back in the 90s, and probably still today in some ways, was one of the preeminent internal medicine training programs in the country, and certainly in the South. To be a chief resident there was quite an honor. They were not used to chief residents becoming internal medicine providers in private practice. The chief residents of UAB almost always went on to do fellowships in specialty medicine. And so at this time in the 90s, when HMOs were kind of version one of HMOs were kind of hot and heavy, and the role of the primary care doctor was being kind of elevated in terms of controlling downstream costs. I was interested in wanting to be in a position and thinking about how to, where do you have impact in medicine going forward? And so I had this sense that maybe primary care and internal medicine was going to elevate. I also believed that there was a lot to be done in the field of cardiology that didn't involve sticking a catheter in someone's groin and kind of blowing up a balloon and putting a stent in the coronary artery. There had been some studies that had really not changed the way medicine was practiced enough around the intensive management of risk factors being as effective as revascularization in mortality and morbidity, and the money was influencing procedures as the preferred way of managing cardiovascular disease, even though there's a body of evidence showing that inflammation and risk factors were really to play, played the seminal role. And so for me, it was a confluence of, wow, the tools and the power to solve the major killer in the United States are within reach of a primary care physician. And I thought the macroeconomic trends in healthcare were going to push more people into primary care. And so my mind was going to a place of, how do we arm primary care physicians with the science knowledge to manage the largest killer of Americans in this country? And so I wanted to make sure I could do that myself. And then once I was able to do that, frankly, wanted to spend a lot of time teaching others how to do it. So you mentioned the event at Pennington. I was doing a lot of speaking back in those days. It was largely on behalf of pharma, and it was probably largely in an era when the scripting for that wasn't as highly regulated as it is today. And so it was an opportunity for me to kind of teach. It was an opportunity for me to synthesize this vast kind of science around cardio-metabolic disease and how to manage it, and then to try to get that into the arms of clinicians and build care models that focused on primary care and primary prevention and even secondary prevention without having to have everyone go to a cardiologist. That was kind of how I was thinking about the field at the time.
Excellent. So come around 2012, as again, another interview that I watched of yours, you tell about this story about you're thinking about moving on to sort of the insurance game at this point, and you have a really interesting interaction with Dr. Paul Grundy, who at the time was the chief medical officer at IBM. He's also sort of known as the godfather of this patient-centered medical home model. Talk about that. Tell us that story really quickly, if you would, because I think that is a nice little segue to, okay, now I'm ready. I've done the cardiovascular and I built up this great practice. I'm ready now for the next phase of this. Recap that story, if you would.
Yeah, it's a two-part story. You've got the second half, but I got to set up at the first half. So first of all, I wasn't sure I was ready for a second chapter in my career. That there were a confluence of factors that occurred that made it possible. The first of which was a patient of mine was the CEO of Blue Cross of Louisiana, and every time he was in my office, I used the opportunity to lament the fee-for-service payment model that was driving all sorts of bad behavior, and letting him know that the care model that I was leading with nurse practitioners and diabetes educators would only really create value for a clinician if there was some sort of a value-based payment, a bundled payment, or some sort of capitated payment. So he was a sales and marketing person. I'm not sure he always really understood exactly what I was saying, but the Affordable Care Act was passed under the Obama administration, and he was smart enough to understand that the historical business model for Blue Cross of Louisiana, single state blue, 74% commercial market share, largest provider network in the state, probably largely an adversarial relationship with those providers to extract the lowest or most preferred reimbursement. great actuaries, great broker relationships. They had a model that was working. And now you had this legislation, the sweeping legislation that was going to introduce a public exchange or require guarantee issue or pre-existing illness coverage. And he was smart enough to understand that for Blue Cross of Louisiana to be successful, it was going to have to manage care through its provider organization, which means it was going to have to pretty quickly build credibility with that provider organization and create the right incentives to extract from that network the value that it would need to be successful as a risk bearer. And so he reached out to me to take me to lunch and started pitching to me the idea of, why don't you come take care of 1.6 million Blue Cross members? In your career, if you're blessed and fortunate, you'll take care of a few tens of thousands. But here you can quote unquote take care of a third of the state of Louisiana by virtue of working with us. And it was an interesting question and opportunity. I'd never viewed myself as a health plan executive or as a business leader in healthcare. And so it was at that time that I happened to be in New Orleans, and I was listening to a talk that Paul Grundy was giving. And I stayed behind afterwards to chat with him. I didn't know him very well, but Paul's a very thoughtful gentleman. And I told him about this opportunity and asked him, what do you think I should do? And he looked at me and he said, well, David, I believe I know enough about you already, just through the conversation, through you being here tonight to hear me talk, that we probably agree that healthcare fails to deliver optimal health outcomes across geographies, and that it costs way more than it should for what we get. Do you agree with that? And I said, yeah, I agree with that. He goes, okay, well, once you agree with that, you have really only two choices. And that is, you can either agree to be part of the problem or you can be part of the solution. He goes, from my perspective, you will never solve this from your chair as a clinician, but you may solve this for a pretty sick state from the seat that you're being offered. And I just remember leaving there going, wow, that is like amazing clarity at a time when I didn't know what to do. And so I ended up doing it. And I will say it was the hardest decision I've ever had to make. And it changed my life and career in ways that I never would have imagined. Certainly you and I wouldn't be talking today had I not made that decision, probably. And so although the first 15 years of my career, seeing patients, building care models was absolutely rewarding. The notion of walking into a restaurant and having a family come up to you and introduce you because you saved the life of one of their family members is something you can't get in a business role. So that kind of like really direct influence on someone's life was something I will always cherish. But the notion to think at scale and how to use your experiences and your thinking and your creativity to solve problems for many people is part of the joy of the work that I've been privileged and just honored to do the last, say, 12 years.
Excellent. And yeah, and then as you take on these new roles, both at Blue Cross and Ochsner, you're beginning to publish. You publish in the American Journal of Managed Care on sort of the evaluation of the quality Blue primary care program. There's another paper in the British Medical Journal, standardizing practice in cardiology, reducing clinical variation and cost at Ochsner. And there's some interesting sort of similar themes here in terms of we got a lot of sort of low quality, unnecessary care going on. And if we just had some standardization with these practices, plus a little medical technology that can help us with that standardization, we get great health outcomes and we reduce costs a lot. Talk a little bit about some of what you learned and some of sort of the key components of both Blue Cross and your Ochsner time on some of these, I wouldn't call them simple, but common sense applications to this value care issue.
Yeah, I think the without going into the details of any of them, which would take us down a rabbit hole, I think the high level learning for me is that in order to create value in healthcare, you've got to have a collaborative working relationship between providers of care, purchasers of care, and you've got to have a captive population that those two can control/influence. If you have those three things, you can create tremendous value. And so both at Blue Cross and at Ochsner, my job was to create those connections, right? At Blue Cross, it was, hey, we're a payer, we control payment. I've got to create connections with a voluntary workforce of providers. I've got to figure out how to enable them to do different things by sharing information in a way that Blue Cross had never shared, by creating an infrastructure to pull clinical information from an electronic medical record in order to assess quality of care, to create a payment model to support the providers who are doing a really good job. And then once you've built that, you've got to go to all of the self-funded accounts, and you got to tell them you need them to participate in a new payment model that sits outside of fee-for-service. So the reality was, when you did all of that, and we were able to do all of that in a pretty short period of time, the payoff was enormous. So the paper you mentioned that we published around Quality Blue, which was our primary care focused problem, where we paid a monthly management fee for every eligible Blue Cross member in Louisiana that had a qualifying chronic disease. And they were the common ones like high blood pressure and high cholesterol or vascular disease, chronic kidney disease, and diabetes. And so if providers were doing a good job seeing those patients and taking care of them, and we knew that because we were able to connect into their EMRs and pull out data to know that, we were willing to pay them more for the fact that they were doing a good job. And we were paying them on a monthly basis, had nothing to do with the patient coming in and having a visit. Yeah. It was rewarding them for taking care of these people longitudinally. And I think providers loved it. We liked it. Our patients tended to like it. And frankly, what we saw that after a year of that, net of all the expenses, all the development costs, all the new payments, we were saving about $27 per member per month. We did not expect that. We thought that by virtue of the investments we were making in new payments, by the fact that we were largely going to drive more visits to the clinician, that we were probably going to drive more drug utilization in these programs, that it might take 2 or 3 years to kind of offset that with fewer emergency room visits and hospitalizations and procedures. But in fact, in Louisiana, we saw that in the first year. So it was kind of an aha moment. Like, if you get these kind of different, what I'll call sectors or of the healthcare ecosystem collaborating, you can create value. And so we took that set of learnings into Ochsner, where we developed payer partnerships with multiple payers, where we worked with employers on direct to employer contracts, where the employer who was self-funded and Ochsner or Ochsner Health Network were kind of the provider collaborators. And we showed again and again and again, when you had these different disparate parts of the healthcare ecosystem collaborating, value was easily within reach. And to your point, it wasn't always complicated. It's complicated to get the right people to the table. It's not complicated once those people agree to do something different, So I think what I've become good at, I think, and maybe it's just something, partly inherent to maybe being a good clinician, where you listen carefully and empathetically and then articulate and communicate succinctly and directly. I've gotten good at bringing together these kind of disparate parts of the healthcare ecosystem around a common vision of making things better. And I think it's really that skill set that ultimately ended up with me coming to Walmart.
And perfect segue, because here you are at sort of chapter 3 of this amazing journey. Take us into, because this is a side note here. So you always knew you were going to be a doctor. I always knew, because I grew up in a family of pharmacists, I was going to be a pharmacist by undergraduate training. And I think maybe looking at the wheel and spoke model of the omni-channel care structure, I think maybe pharmacy was Walmart's first thing. They were back in the 70s when the first Walmart started opening pharmacies. Now, there's a Walmart about a mile in that direction, and clearly there's much more going on there now than just pharmacy. Take us into Walmart Health, take us into omnichannel care, and a little bit of this full-service community health centers, because, again, you're doing dentistry and physician visits and audiology and a long list of stuff that isn't the Walmart of yesterday. Take us into this for a little bit, if you would.
Well, so what was I'll just start at the beginning about why Walmart for me at this point in my career. First of all, having spent most of my career in the state of Louisiana, which is incredibly gratifying because my whole family lives here. My brother, my two sisters, my parents, we all live in Louisiana, 49th through 50th in healthcare outcomes. So really have enjoyed trying to make a difference in healthcare in Louisiana across lots of different roles. I was ready to do some, with all these very unique experiences, there just weren't lots of folks who were physicians who've had the variety of experiences that I've been able to have. And so I was wanting to challenge myself more at scale. I was looking at how do you make an impact on a more regional or national level than maybe my career had driven me to. And where was healthcare interesting, right? Where was it really interesting? What are the kind of vanguards of healthcare change? And I think there's a few, private equity being one, the retail or kind of disruptor, new entrant into healthcare is another. And I gravitated, I was really interested in what Amazon and CVS and Walgreens were doing, what Walmart was doing. And the reason I was interested is here were scaled companies that existed in the community that had large numbers of customer relationships already, who were really wanting to do something different in healthcare, and they wanted to do it leveraging, modern information systems, modern technologies, and modern payment or different payment models or different ways to monetize activities in healthcare. I thought that the historical constraints that make it really hard for legacy healthcare companies to make wholesale change didn't necessarily exist in the retail world. And so for that reason, I was open to come into Walmart. Walmart, to your point, has been at healthcare since the 70s in pharmacy, and then more recently in vision centers and optical services. So probably the scaled healthcare offerings for the last couple of decades have been in those two spaces. Since the call it, 2006, 2008, Walmart has explored primary care or urgent care in a variety of different ways, has also dabbled in dental through kind of leasing spaces to independent dentists and seeing how Walmart customers appreciated that or not. So a series of learnings that ultimately culminated in 2019 with kind of the launch of what is currently known as Walmart Health. The thought about Walmart Health was we want to bring healthcare into the community and make it more accessible and more available to folks by virtue of co-locating it where they live their lives. So instead of having someone have to leave their bubble and their world and drive across town to a healthcare facility to have healthcare, where are people already coming? And 90% of America lives within 10 miles of a Walmart. 20,000 plus people walk through a Walmart supercenter on a given day. There are 5,000 roughly, maybe 5,100 Walmart supercenters in America. 4/5 of them are in HRSA designated medically underserved communities. So Walmart sits at the intersection of where healthcare access starts to break down in America, right? It's not inner city where there's a provider and multiple hospital systems on each corner. It's out in the suburbs or in more rural markets where really access to primary care and dental care and all is spotty at best. And so the notion was, let's co-locate core services that are really critical to part of people's kind of pursuit of general health, right? So good, high quality primary care, urgent care for acute, care, urgent care visits, behavioral health, because of just the significant burden of behavioral health challenges in America, but also the multiplying impact it has on chronic comorbid disease conditions, and dental services, lab and basic x-ray. Let's put all of that together under one roof in a modern facility. If we can put it inside a Walmart, that's great. If not, let's attach it to a Walmart. Let's make sure that folks who are coming to Walmart and maybe using our pharmacy or grocery or retail merchandising area also have access to healthcare services. And that's the journey we're on. When I got to Walmart Health about 18 months ago, we were operating 20 of these health centers. We had launched them in the greater Atlanta area initially. We have 17 sites there. The first one in Dallas, Georgia was around 11,000 square feet. They're huge, so very big, very modern, very nice, well appointed, but super expensive, frankly. And so we've shrunk them down a little bit and lost some of the wasted space, and now they're around 6,500 square feet. These are really, really nice places to get healthcare, and we've hired board certified physicians and dentists and nurse practitioners and dental hygienists and equip them with modern technology, a modern electronic medical record with Epic, and we're trying to prove, frankly, that Walmart customers, of which there's a couple of 100 million in the United States, will choose to receive healthcare because it's convenient and accessible, and I think ultimately will create a set of differentiated experiences. I like to say, what is the experience that could be differentiated at a Walmart, and why would someone come to Walmart? This notion of going to a discount retailer for healthcare is probably foreign to a bunch of people. The notion of discount healthcare doesn't sound super appealing, right? But I think those of us who've been in healthcare for a long time know that in many cases, the highest quality healthcare in the world is the least expensive. And so, but because it's hard to win kind of the hearts and minds of customers on that kind of logic, you have to create experiences that they appreciate. So for me, the kind of prototypical experience that I believe we can create at a Walmart Health, that I think your listeners will resonate with, would be like a diabetic who has a busy family, who is coming to the store, needs to pick up some things at the Walmart. By virtue of the fact that they come to Walmart once a week, we have the opportunity to intercept them a couple of times a week or a month if we want to, and do things for them in our clinic. And so perhaps they stop in and have a primary care visit, maybe walk out of our clinic with a community health worker and walk straight over to our grocery aisle right outside the store and have a brief education around healthier food choices for their diabetes, and then stop at the pharmacy and pick up their medications on their way out the door. So the ability to kind of do clinical care, maybe even an eye exam if they needed one, teach them about healthier eating in our grocery store right there, and have their medications coordinated all under one roof with one visit, is something that I just don't think healthcare can deliver anywhere else in the country. And I think as we're starting to be able to predictably do that, we're getting really good feedback from people like, wow, not only was this super easy, it was actually different. It felt different. It felt comprehensive. It felt holistic. It didn't feel disease focused. It felt like you guys are interested in my whole health and well-being. And I think that's what we're shooting for. And so over the last 18 months, we've been about opening more of these, right? And so we've learned through the first 20. We're opening 3 this week, actually, in Jacksonville, Florida. At the end of this year, we'll have about 50. At the end of next year, we'll have about 80 across multiple markets. And so I think what we've done is learn how to create a model that folks are liking. Providers are enjoying it, frankly. Patients are having good outcomes and good experiences. And so now we're just starting to pour fuel to the fire a little bit and start to grow the footprint to impact more people.
Mm-hmm. And David, that equation that you just laid out there, so healthcare service plus healthy food plus access plus value equals healthy community, and this obviously the social determinants of health is such an important topic nowadays, and I know this is a key part of your portfolio. Say a few words about social determinants of health per this model, and then I also noticed there was a collaboration that you recently entered with an organization called CareSource, specifically looking at economic and racial health disparities, and talk a little bit about how Walmart is thinking about this within the social determinants of health umbrella.
Yeah, I appreciate you asking about it. Probably I'm guilty, like most people who've grown up in traditional healthcare, at I'm guilty of underappreciating the real impact that we as clinical care providers actually have on someone's health relative to the community they live in, relative to their genetics, relative to the choices they make. And I think, part of the challenge we have in America is that we've invested heavily in care delivery. And in other parts of the world, they've invested heavily in services that support people living healthier lives, access to healthy food, access to transportation services, access to a good job, access to education, things that allow people to be smarter, to have a better economic reality, and to be able to access healthcare. This notion that your zip code, probably has more to do with your life expectancy in this country than anything else is really telling. And I think Walmart is a scaled enough organization to actually not just think about it, but to do things about that. So in 22 states in America, Walmart's the largest employer.
Yeah.
Walmart has 1.7 million associates in the United States. So we take care of a lot of folks who work for us, frankly. And so the ability to think about the needs of these associates who live in the communities that I mentioned, or which are largely medically underserved, is just natural to a Walmart. The other thing that's natural to a Walmart is that it's always thinking about the problems that its customers face. And so again, that takes you into this notion of social determinants, right? If you don't have a healthy place to exercise, you're probably not going to exercise. A safe place to exercise, you're probably not going to do that. If you don't have ready access to affordable, healthy foods, you're probably not going to eat healthy foods. And so I think what Walmart is wanting to do is to leverage all of its assets. Walmart increasingly is a diversified company. It has a financial services arm to it now. So ability to help people finance certain types of purchases is within our reach. Teaching financial literacy is within our reach. Providing access to curated healthy foods is within our reach. Providing access to jobs and a career pathway is within the Walmart direct reach. So Walmart has these tremendous assets and sits in a unique place in the community such that it can think about how it directly influences that. So as a healthcare delivery expert, I certainly want to leverage that. And so the notion is that, if we can develop clinical relationships, trusting clinical relationships with people and wrap them with a set of social determinant health focused efforts, that could create real value for individuals and lead to healthier lives. And so you mentioned CareSource. CareSource is a national insurance company. They focus heavily in the Medicaid space. They're actually a non-for-profit Medicaid company. And they were interested in partnering to kind of test this hypothesis of how could Walmart plus a payer partner to deliver an SDOH program. And they were interested in a couple of different pilots, one around maternal child health. So in the United States, in many communities, there's an inordinate amount of kind of maternal morbidity and mortality, and also suboptimal birth outcomes that are largely around healthy lifestyle choices for pregnant moms and good prenatal and postnatal care. And so that's one population. The other population was just cardiometabolics, patients with prediabetes, diabetes, and who maybe live in underserved communities. And so in both cases, we're partnering to work with them. They have eligible members. They'll feed us a file of those eligible members, and then they will fund a directed spend card that allows access to healthy foods or OTC prenatal vitamins or other prenatal supplements. And then we'll engage these members. We'll do proactive outreach. We will have community health workers in some of our stores. We'll have teledoula services that'll be wrapped into this for pregnant moms, telenutritional counseling. And so the goal is to say, hey, working with a payer in Walmart and services that can be aggregated at Walmart and engaging people where they live, can we do something different to influence the health outcomes of folks. And I think it's a point of, kind of a proof concept to say, hey, we think this will work. And if we can show that in this pilot, it works, then I think you'll see us rapidly start to look for other opportunities to scale that. So that's just an example.
Mm-hmm.
We're thinking about social determinant kind of work at Walmart.
Excellent. Excellent. And you mentioned, so the tele component there, and clearly as much of the omni-channel model that is physical, there's a major digital component. Can you say a few words? I mean, you have a telehealth provider called MeMD, which does telehealth for behavioral care. You have an interesting new diabetes program. Again, thinking back to the diabetes story with the American Diabetes Association. Talk a little bit about the digital component of the omni-channel model, and then if you could say a few things about sort of how you evaluate some of these, because there's obviously it's the Microsofts and the IBMs and so forth of the world, but there's thousands of sort of small digital health players out there that are coming on the scene. How do you juggle all that stuff when you evaluate some of these tools for an organization like Walmart?
Yeah, well, certainly it's a work in progress. I think if you start with how Walmart itself, broad Walmart, views itself today, it's people-led and tech-powered. So Walmart itself has become an omni-channel retailer. If you think about it, our investments in e-commerce, Walmart Plus, our membership model, but also just the ability of consumers to have really great experiences on Walmart.com and really able to have the power of a Walmart supercenter in the palm of their hand at all times. Part of how Walmart is thinking about retail. I don't think we're thinking any differently in healthcare, right? I think at the end of the day, there will be consumers who at times will want to receive healthcare services where they live, virtually and conveniently through a channel such as an iPhone or on their computer. There'll be other times when they're going to need or want to come and have an in-person clinical visit. So this notion of a connected care model, ideally with a longitudinal medical record, so that information across those different channels is married and not lost, is kind of our mindset in general, right? So we did acquire a company a couple of years ago, MeMD. Mm-hmm. They were a national telemedicine company, largely in the B2B space, though. So they were sold through distributors to employers to provide access to virtual care capabilities. The work we've gone about doing with this asset now is to figure out how to more tightly integrate that into a model that starts with clinics and with in-person relationships and Epic as an EMR system. And so replatforming, if you will, that asset on Epic so that patients coming to us through either channel will have a longitudinal record that we can maintain over time is kind of what we're about. So layering on to that, digital capabilities, remote patient monitoring, things in the home are part of our roadmap. But what we want to do is make sure that we do it thoughtfully. There's like a gazillion point solutions out there, digital health opportunities. I think if you talk to purchasers, if you talk to employers, if you talk to many of us who watch healthcare, it has the risk of creating lots of little different silos. And I think what we want to probably do is make sure that we're unifying experience, single sign-on. We're looking at kind of making sure we don't lose pieces of information as we deploy digital solutions, that we also don't overwhelm our providers with digital data and information. I think that's another risk that we run. So, it's great that we can do remote patient monitoring, and you could be my patient. You could send me blood pressures a month, but if I, as a clinician, am having to actually sift through that and make a determination about something that needs to happen, that's going to impose a pretty significant burden on me, given everything else that I've got to do as a provider. So being thoughtful about how that data gets generated, where it goes, how it gets curated and analyzed so that it can be acted upon in a thoughtful way is something that's kind of top of mind for me. So we see, we could spend another hour on this particular conversation. I'll just say, I see digital and virtual as really important parts of how we deliver care in the future. However, I think for the Walmart customer, it's going to be really important that we also have in-person care. I think Walmart's differentiator, frankly, is its people and its scaled bricks and mortar. And I think virtual only companies are going to struggle to be transformative change agents because those models can only take you so far. And there are really important parts of healthcare that are intensely human. And I think if you start with people and add tech, you have a better chance of making this work than if you start with tech and try to figure out how to solve for bricks and mortar access. So I do think, my hypothesis is that Walmart with 5,000 stores and 1.7 million associates and millions and millions and millions of consumer relationships, adding tech thoughtfully to that front door is the way that we're gonna win and impact healthcare productively in this country.
Outstanding, really outstanding. One other thing I wanted to ask about while I have you today, thinking back again to that presentation back in 2012 at Pennington, and one of your slides was entitled like what kills us, and there was a heart disease, cancer, diabetes, lung disease on there. All what one could consider as we look at the picture now as sort of the diseases of older age or the diseases of aging. And I came across, I know this was a little bit before your time, but an interesting conference at MIT back in 2020 in the Age Lab, sort of talking, and there was a representative from Walmart there at the time, sort of talking about aging and sort of the social determinants connected to sort of the older population and sort of these important connections, something you've talked a lot about, and not just keeping the elderly population connected, but also, connecting old and young, the intergenerational component of health and vitality. Anything just while I have you, anything interesting that you could say going on that particular front? Because that's a sort of an important piece, sort of what we focus on the show, is sort of this theme of healthy aging, health span, longevity. Anything interesting happening there pertaining to Walmart?
I can't speak to specificity or with detail about some of it. I'll speak thematically, and that is that there is a significant interest at the Walmart Inc. level around providing retail services or retail access in the home, or being connected to the home through a variety of different mechanisms. Today we do home delivery. There are people who let us deliver groceries to the home and into their home. And frankly, some of us let us come into the home and put the groceries in their refrigerator. So the trust that Walmart has built with consumers is a basis for thinking about this problem that you just raised in your question, which is, okay, if from a retail perspective, seniors who are aging increasingly at home and not in the facility are engaging with Walmart, and maybe it's convenient for them for food or their medicines to be delivered to their house, well, then what else could we do if we were in the home, right? Could we do fall assessments in the home? Could we think about reconfiguring the home to make it safer? Could we think about using technology to monitor folks and create connections from those insights to maybe their caregivers who may be younger and live out of state, but who may be interested in whether mom or dad are up and around and healthy. So suffice to say, Walmart believes the home environment is really important for its global business. And I think we would expect that healthcare will come along for the ride a little bit, but maybe not in a pure healthcare in the home way. Maybe it's as part of a kind of a combined offering. The last thing I'll say is just that, when we get into this space from a healthcare perspective, the payment model, again, I mentioned this earlier, matters a lot. And so in the senior space, we like risk-bearing capabilities here, right? We like capitation as a payment model. We like having full responsibility for the total cost of care for a senior. And, we've announced that a 10-year relationship with Optum and United to partner to do full capitation Medicare Advantage risk is kind of our first effort to understand how do we take all of the things I mentioned that come together at a Walmart and develop kind of primary care relationships with seniors, and then take full responsibility for their total healthcare costs. When you have that economic model in play, then investments into the home using technology to maybe kind of think of bots or sensors or other things in the home that kind of help people live healthier and stay healthier in their home, becomes economically viable, because now we don't have to worry about how we're going to get paid for that. So I think the connection to being willing to take risk in senior populations, and then what that frees up for us to think about and do in a home on behalf of the seniors is pretty evident.
Absolutely. Yeah, I love the sort of the aging in place theme. And I think obviously an organization like the one you're building is perfectly positioned to move that forward in a major way. Dave, one last thing while I have you, I noticed that I think back at the end of March, you were, a speaker at the Vive conference in Nashville, amongst, all the other major health sort of tech luminaries. Anything else happening that's hot on the calendar? I mean, obviously you're opening all these centers, but other public facing initiatives, conferences you're going to be presenting at, places you're going to be speaking, potentially we can see you, meet you. Anything else hot on the calendar, please?
Yeah, I mean, I think probably from an initiative perspective, in addition to opening new centers kind of for a long time, I mean, we'll be opening centers ongoing for years. You mentioned the CareSource relationship. That's a really important one, and I would imagine we will wait and make sure we execute that one well before we announce other types of relationships like that. I honestly have spent my time this year and probably into the next year largely on execution. There's no limit to thinking about what a Walmart can do in healthcare, and it certainly would be. It's fun to go give talks at conferences and to think. I think at the end of the day, I want our execution to speak for itself. So building the right team, recruiting that team, making sure we have the right resources, making sure that we've learned how to communicate our value prop to customers. Making sure that we're able to attract a really high quality workforce of clinicians is really so it's a little internal for now, only because we're in early days at Walmart. And I just want to make sure we get this done correctly. I think as we have stories to tell, we certainly will tell them externally, but if you don't see a lot of me on the stage over the next 12 months, it's not because we're not interested in it. It's just that we have a really clear idea of what we want to do, and we think our success or failure is going to be largely determined by not how much we talk about it, but how much we actually start executing on it. So more to come. There will be lots of things to come from Walmart Health, but in the next 6 to 12 months, it's largely internally focused.
Well, I for one will be rooting you on. Amazing journey, David. An amazing future for what you're building there. Again, for everybody that's going to be listening to this particular episode of the show across the various podcast networks or watching on the YouTube channel, you've been spending time with Dr. David Carmouche, Senior Vice President, Omnichannel Care at Walmart. David, again, thank you for taking the time out of your schedule to come talk to us and educate us on these topics for a little while. Obviously, thank you for everything you're doing there. And as we like to say here on our show, thanks for helping to create a better tomorrow for hundreds of millions of people via what you do. Really great story.
Well, I appreciate you having me, and thank you for just having a format that allows me to kind of talk about this in one sitting. It's rare, and I certainly appreciate the invite, and hope it was interesting.
Great having you.